Spherical aberration is naturally occurring in human optical system aberration, which means phenomenon in which the outer parts of the lens do not bring light rays into the same focus as the central parts. Spherical aberration occurs both in cornea and natural lens. In youth, negative spherical aberration of the lens compensates the positive spherical aberration of the cornea, thus giving us perfect sharp vision with no depth of vision, which is not so important for us because we can accommodate as long as we are young. Later, the spherical aberration of the natural lens is becoming neutral, then positive, so the total spherical aberration of the eye is becoming more positive, thus giving us much more depth of focus. Positive spherical aberration is when peripheral rays are focused in front of the central rays. We need to remember that natural cornea has positive spherical aberration, and these aberrations stay positive for the whole life, of course without refractive surgery. So the spherical aberration of the IOL is quite important, especially in patients with pupil wider than 6 mm, when perception of higher order aberration is much more significant. Implanting a spheric IOL with negative spherical aberration reduces the whole spherical aberration of the optical system and gives the patient perfect sharp vision with no depth of focus and very small tolerance to ametropia. Implanting older type of spherical IOLs with positive spherical aberration can increase the amount of spherical aberration over the tolerated level and in the end decrease the contrast and cause dysphotopsias. And now we have also aspheric IOLs with positive spherical aberration, and here we have EMV, which induce a small amount of extra positive spherical aberration and increase the depth of focus. Spherical aberration are important when we choose monofocals or monofocal plus lenses. Multifocals or EDOF IOLs are based on different diffractive or refractive mechanisms. When we have a patient with no history of refractive surgery and naturally positive spherical aberration of the cornea, I think that the best option is to implant either a spheric IOL with small positive spherical aberration like EMV, or aberration neutral aspheric IOL, for example, RayOne aspheric. After myopic LASIK, it depends on the amount of spherical aberration. If they are high, I would choose aberration neutral IOL. If low, small positive spherical aberration IOL to increase the depth of focus. After hyperopic LASIK, it also depends on the amount of negative spherical aberration. Usually they are not so high, so in my opinion, the best option is to implant negative spherical aberration IOL or aberration neutral IOL. The selection of patients for EMV is much easier than for multifocals for me. Of course, patients cannot achieve such good near vision, but intermediate vision is satisfactory in combination with micro-monovision. They can be independent from glasses in majority of situations. And what is most important, lack of dysphotopsias makes this lens appropriate for patients with high demands on quality of vision, especially night vision, where small reading glasses are not a big problem. I use EMV as a standard monofocal lens with the same approach. At first, I implanted EMV on ametropia, and in fact, I found quite nice results with usually satisfactory intermediate vision and small reading glasses, usually no more than 1.5 diopter. Of course, when we want to give our patients more independence from glasses, we use micro-monovision. Usually, I don't go over 0.75 to 1 diopter. What is really important, and I think crucial when explaining to the patient, is that it is not a typical monovision with all its drawbacks like decreased stereo acuity or intermediate vision and poor tolerance, because only about 65% of patients tolerate typical monovision. Here we have enhanced monovision. It means that the distance eye has a depth of focus and gives also intermediate vision and helps the near eye and vice versa. The binocular vision is much better with spherical aberration, and such monovision is much better tolerated. It provides smoother transition between distance and near eye. When targeting post-operative refraction, we need to remember that EMV is a positive spherical aberration IOL. Such lenses should always be targeted on plano, or rather even on the first plus. With negative spherical aberration IOL, we target on small minus, and this is the difference. Personally, I don't have any experience yet with EMV after LASIK, but I use this lens as monofocal, so probably I would consider implanting EMV, especially after low diopter myopic LASIK with small amount of positive spherical aberration, just to increase the depth of focus. Of course, adding the toric EMV to the portfolio of EMV is very important. However, I found that EMV is a little bit more tolerant to residual astigmatism, probably because of the spherical aberration. I implanted toric EMV and the results are very predictable and stability is really good. I use the Ray Trace, the online calculator. I find it very comfortable, easy and intuitive to use. It does include PCA, posterior corneal astigmatism, for more accurate toric IOL calculations. In my opinion, taking part in conferences like ESCRS are one of the most important parts of our work as cataract and refractive surgeons. Now, after ESCRS in Vienna, we can see that there is a shift, a significant shift towards refractive rather than diffractive IOLs, EDOF rather than multifocals, and monofocals, monofocal plus lenses rather than monofocals. Watching and sharing the experiences with others can give us inspiration to change our everyday practice. Thank you very much.